Hi everyone, this is Neil Writer, consultant audiologist and director of ClearWax. Thank you for joining me in my latest video using the iClearScope endoscope. And this was a really complex case. I'll give you the backstory. So this patient actually attended today and we had a free slot and the patient was nearby. They actually went into a walk-in centre because of the pain they were experiencing in their right ear. And they were given our details and they called and said, we've got an appointment in 10 minutes. We've got one slot that became available. So if you can make it in that time, then we can see you. But after that, we were fully booked. So this patient attended straight away and they have been experiencing tinnitus. So tinnitus is a sound that originates within the ear or inside the head. So it's not an external sound. And they've been experiencing this for the last 5 days alongside, of course, really reduced hearing, and their main symptom was severe pain, altalgia in their right ear. They saw their GP yesterday who advised to use some drops, and this patient used carbamide peroxide drops, which is probably my least favourite. Carbamide peroxide drops is a 1-to-1 solution of urea and hydrogen peroxide. And they said after using the drops, it exacerbated their symptoms. Truth be told, whatever drops they used may have done that though, because this wax impaction was so severe, it would have absorbed the drops, further expanded because it's already impacted and right up against the ear canal and eardrum. So today they went to an emergency walk-in centre, and they don't perform earwax at these walk-in centres. So fortunately, they were able to book in with myself, and this patient just wasn't able to hear at all from their right ear. Now, their left ear was bad as well, but in comparison, it wasn't as severe. And they've previously had earwax removal several occasions elsewhere in the past, and indirectly they kind of laid the gauntlet down. So when I began the procedure, I did explain to them that this is going to be quite a tough one. It's going to take me a while, but I will get it out. And they just queried, am I sure whether I'll be able to get it out? And I said, yeah, confidently, yeah, I should be able to get this out today, so don't worry. And they later explained that in the past, every time they've had their wax removed, it's taken several attempts, so not on one appointment. And it's also been very painful for them. So they were delighted that we were able to remove this today, and also pain-free. It's always difficult when a patient attends already reporting altalgia, so ear pain. We're entering the ear that's already painful, and we're having to maneuver and manipulate the wax. So I was doing it as gently as I possibly could. So far I've used microsuction and the Corette, but microsuction just wasn't going to remove this. I could put oil in as much as I want during the procedure, but it was just so dense and so impacted. I'm going to try and come up with an analogy so you guys can better understand what I'm referring to when I say it's impacted. And probably the best one I can give is if you've got you go to the beach, you've got some wet sand, you get your spade, put it in the bucket, and then you get the spade and you just hammer on top of this wet sand and you impact it inside the bucket. So I'm just using, I think it's the right ear hook here. I wanted to get over and beyond, and I did, but because of the consistency of this, it just cut through. So I've just put some more drops in because we've created a bit of an opening around the edge. I was hoping some of this oil will seep in and behind the wax, lubricate the canal wall. But truth be told, it didn't really do much. So even here laterally, I'm trying to remove this from the floor of the ear canal, but it's quite matted. There's quite a few hairs there. And posteriorly, so to the back part of the ear canal, the first bend, there's quite a few whiskers of hairs. So sometimes, because we were trying to visualize the wax in that region, the endoscope had to be in that position, because we're also using the endoscope not to just visualize the earwax, but also to open up the entrance of the ear. So inevitably, if you've got hairs in that region where we're having to push open the ear, you're going to See a few whiskers of hairs there. So I'm just kind of, I think I'm going to go, let's see, I'm using the ear pick and I'm trying to go over the top, which I managed to do. So in my head, I've done the hard job. I thought, yes, I've managed to get the instrument over and beyond, but just like the ear hook, it just cut through. So the only instrument that's going to really remove this is the correct. And also the microsurgery, I said it wasn't effective. It did help a little bit, especially when I was cutting and dicing the wax using the hook and the pick. You can see all those hairs matted, which does make it more difficult to get a suction grip. But when I was positioning the suction tip on the surface of the wax, you can just feel that, is this really going to come away with the suction? And the reason why I'm persevering is because now we're entering the inner 2/3 of the ear canal, at least on the right hand side anteriorly, and the flesh you're seeing there is just actually bone with the thinnest wafer thin layer of skin lining it. So the skin that is lining that bone is around 0.1 millimeters in thickness, and if we make contact with that bony part of the ear canal, it's like you bump your shin onto the edge of a door or a chair. It's that sharp acute pain, and I've experienced that before, hence why when I'm performing procedures that deep, or whenever I'm performing a procedure, I'm just always trying to be as gentle as possible, which we all should, if truth be told. So it's nothing different that I'm doing. Everyone that performs earwax removal, their ultimate aim is to be as comforting as possible and reduce any unnecessary pain and duress. And you can see it's just pushed right up against the canal walls. It's up against the eardrum. They don't use cotton buds, but they do wear ear pods, and sometimes they do leave them in their ears overnight so they fall asleep whilst listening to music. So I have suggested that they come every year now. So I think the last time they've had this removed was about 3 years ago, and to see if they can convert to over the ear headphones as opposed to in the ear pods. Now, I did pre-warn the patient because I just knew I'm going to have to use the correct here. So glided in. Problem is, we just don't know exactly at this stage where the eardrum is. If I went any further, glided the correct in any further, I could have easily touched the eardrum, made it even more uncomfortable. But you can see there's still another layer here. So I'm just going to the top. And the Right Correct really, for me, it's probably been the best instrument that I've developed because of its design. It's curved to mimic the curvature of the ear canal. The end of the Correct, it's also tapered, so I'm able to get into the narrowest of spaces, or even when wax is compressed right up against the ear canal, I can glide more often than not in between the wax and the Correct. Now, you can see I'm scooping a lot of this wax out, but at the same time, the wax you're seeing to the right, when I'm inserting the Correct and trying to scoop it out, it is possibly compacting it a bit more. So I've decided to just use the suction probe here because there's now space to the right of this wax where I've scooped the previous wax out. If I can push this wax into that opening with the suction probe, I may be able to release it, but it's just too matted. Just see how dark this is. It's been there for such a long time. So again, I've managed to open up the. I'm trying to go underneath it to see if I can lift it up, but it's just too dense. So I'm just going to use the tip of the Correct to kind of cut into this wax and then come away. So you can use the Correct also in that method. You can, if it's a soft but firm type of consistency, you can use the tip of the Correct to embed into the wax. With the previous Jobson horn that I used, it just wasn't possible to do that. Now, I'm just using the ear hook posteriorly because this bit was a bit firmer, and I just thought if I can just dissect this with the hook, which I have, so it's loose in the air. I think I'm going to use the suction probe now Now, of course, we can't use forceps with this type of consistency. It's not designed for this type of consistency. Again, I'm just trying to go to the back part of the ear canal, trying to elevate this, separate this from the posterior canal wall. And there's those hairs that I was making reference to. Most of us have these hairs, and they normally protrude from the back part of the ear canal where the first bend is. Now, these hairs should only be located on the outer third of the ear canal, the cartilaginous portion. And that's because this portion of the ear canal where the cartilage is, the skin that lines the cartilage is a lot thicker than the skin that lines the osseous portion, the bony part of the ear canal, the inner 2/3. And the skin that lines the cartilage has 3 layers. You have the epidermis layer, which is the most superficial outer layer, which also lines the bony part of the ear canal. But in addition, the cartilage also has the dermis layer, which is the middle layer. And it's the dermis layer that contains the hair follicles. And then you have the subcutaneous or hypodermis layer, which is the most deepest layer of skin. And that's primarily composed of adipose fatty tissue. So since the inner 2/3 of the ear canal, the skin doesn't contain the dermis layer, you shouldn't find any hairs protruding out from the ear canal in the inner 2/3 of the ear canal. So all these hairs that you're seeing matted to the wax, they've either been pushed in by the patient, or when the patient's been trimming the hairs around the ears, some of these hairs have flown into the ear and matted up against the wax. So I may have just put some more oil in there. And what am I going to use now? Just a suction. I'm just trying to lift this part away. It is partially off the canal wall now because I used the ear hook previously, but it's still so dense. Now, this patient may have previously had a keratosis obturans. This isn't keratosis obturans, this is earwax. There's a big difference. A keratosis obturans is an epidermal skin plug. So that epidermis layer of skin that I was making reference to, it forms into a plug. It fails to migrate out of the ear as it should. So the skin that lines the ear canal and the eardrum, it should move sideways towards the entrance of the ear canal, where the individual skin cells then separate from one another and flake away and desquamiate, so shed from the ear. So this isn't dead skin. Now, earwax does contain dead skin. Majority of earwax is. It is dead skin, about 60%. But earwax also contains natural oils and sweats. So one of those is sebum, which is secreted by the sebaceous gland. So sebum is an oily lipid secretion, similar to, not similar, exactly the same as the oils that our hairs on our scalp, for example, produce. And it also contains a lipid-rich, oily sweat, which contains loads of proteins as well. And that's produced by the ceromunous glands. So the ceromunous glands are, in the ear, they're modified. So they're different to the normal sweat glands that you find on your brow, which secrete water and salt. These are, as I said, they secrete an oily, lipid, protein-rich sweat, similar to the sweat you find under your armpits, for example. And they amalgamate to form earwax. So this is definitely earwax and not a keratosis obturans, but it doesn't mean that they previously didn't have a keratosis obturans. And the reason why I'm making reference to that, because they had quite a wide ear canal. So keratosis obturans can lead to global remodeling of the bony part of the ear canal. And the patient, in terms of their age, they fit that profile. I think they're in their mid-30s. Let me just double check that. Yeah, so then the early 30s. So keratosis obturans is a pathology more common in younger populations. The ages between 20 and 40 is when you're most likely to develop keratosis obturans. So again, I'm just using the suction probe, but it's just lodged, and let's see what I do now. I think I'm going to use the curette, and I will in a moment. I'm going to go into that space. I was trying to avoid it. A lot of people ask why we don't use manual instruments really deep in the ear. And it's because if you've had the procedure performed yourself, or you've had it done in yourself, you'll have an appreciation of how sensitive the inner 2/3 of the ear canal is, and even a bit of pressure can be painful. And this patient is already experiencing ear pain, so we're up against it. So I was trying to avoid it. And again, I just don't know exactly where the eardrum is, how thick is this layer, but I just prep the patient, explain they may just feel me glide in. The curvature of the carrette though really helps in this type of procedure. With the previous Jobson horn, I wouldn't have been able to get in and behind that. It was too chubby and it was a flat scoop, so they would have found a bit of friction up against the canal wall. So I'm going to go a bit lower, I think, or am I going to use the suction to remove some of that? So I'm just pushing it inwards. I want to see where the eardrum is, so I've got a better idea of depth. And as I'm bringing that out, you can see some of that wax got trapped in the little open hole. Still can't see the eardrum. And I think I'm just going to go over the top now and get this portion to the left. And sometimes when you bring this away, the whole deep plug can also come away. So that's, and I think at this stage the patient noticed a significant improvement in the hearing, as I think I took it off the eardrum. Now there's a lot more space over the top for me to get right in and behind, but it was still a struggle. And as I'm bringing it out with the carrette, I have to navigate the curvature. So you can see the ear canal does bend left to right, and there's also an upwards trajectory as I'm coming out with the carrette. So not only am I having to manipulate the carrette left to right, but near the entrance, I'm having to go upwards as well. So this is near the first bend. You can see all those hairs. Sometimes a bit more tricky when you're removing wax near the entrance because the endoscope isn't really resting on anything. When we go deeper in the, as I explained, we use the side of the endoscope to open up the first bend, so you've got a bit of support there. I thought that was the last plug, that was a huge plug, but you can see there's still a hell of a lot more. And again, there's the slightest gap there, over and beyond. I'm just using it like an ice cream scoop. And I'm coming away and I'm having to go up in a moment. I have to, so I can get it out of the entrance. And I was applying a lot of pressure. So you can see the eardrum in the distance now. So I'm just going to go anteriorly into that gap that we created and over the top. And then in and behind, and I'm trying to get to the left as well, so we get all of this plug out. You can see a few hairs came away, and that was a patient was really shocked when they saw all the wax that we removed. So everything's intact, eardrum's nice and healthy. You can just see how red, there's a lot of erythema of the ear canal, and that's because of the compression. This is so compressed, and the ear canal, it's very circular, it's very round. Normally your ear canal is an oval shape, the height is greater than the width. So moving on to their left side, so in terms of volume of wax, there's probably a similar amount, but this wasn't impacted, so it's a bit easier to remove. So again, I'm just using the carrette, and I could just feel how dense this was. I think I mentioned it to the patient as I was bringing this out. Now on this side, I think I just caught the bottom of the ear canal. They have got quite a bumpy ear canal. You'll see it a bit later. The patient didn't experience any discomfort, but it was a bit red then. I think the tip of the carrette, as I was scooping out, it just grazed the surface there. And again, they've got quite a few hairs protruding from the top of the ear canal here, actually, and also from the back. So this is, although it took me about 5 or 6 minutes, it was a lot easier, significantly easier than the other ear. Okay, I'm just trying to find where the canal wall is so I can get in between, but it's difficult to see because of the hairs. I'm just pushing the wax inwards. I'm just going to try and remove this segment, so I'm going to get the tip of the carrette into the wax, cut it away and remove it. There's a bit of a gap there. So I'm going to get the carrette into the gap. Now I'm going to try and upload another video which I used the wax scope, and it was actually a very similar amount of wax that I removed. It's from my uncle's ear who attended yesterday, and that took up a similar amount of time. You can see at the bottom, you'll see it a bit more clearly. I think I just caught potentially, unless it was there previously, but I'm not gonna pass the buck. It may have been me because I did scoop down in that region, and it was quite, again, the ear canal was quite bumpy, so until you can visualize it, wasn't expecting that bump. As I said, the patient didn't feel anything whilst I was doing it. So I'm just trying to clear the midsection now before we focus on the deeper bit. I think the deeper part I used suction. It wasn't as impacted, so it was easier to remove. So I'm just going to cut into it using the tip of the curette and then slowly glide away and forwards. But just be careful. Now I kind of know it's a bit bumpy at the floor of the ear canal. I don't want to graze the floor. I think I just put some drops in now, and I'm going to revert to microsuction. Just going to clear this bit near the way at the end. This is an annoying piece here. And I'm just peeling inwards to the middle, so we separate it from the posterior canal walls. You can see some of the hairs are attached to it. The patient could feel the hairs move as well as I was trying to bring this away. Having to use this up and down rocking motion to separate it. So I'm just going to separate this from the floor of the ear canal. So I'm just going to hover over the top, and then as soon as I feel like I've got a good grip, lift it upwards and away. You can see some skin underneath. Again, it's just a few hairs in this region. And now I'm going to focus on the anterior canal wall. I'm going to peel this into the middle. You can see suction's far more effective in this ear than it was in there right ear. Again, I'm just peeling in, there's a bit of a thin layer of skin there, which is quite a sticky layer of skin. So I just want to separate that. You can see that particularly here where there's a skin adhesion here that I want to try and break. I'm just trying to wriggle this away. We managed to get a decent suction grip. Sorry, my phone's beeping away in the background. There's a bit of drama in the audiology world, as there always is. I'll probably explain in a different post, but you can see that's the eardrum. You can see the long process of the incus. See the ear canal is a bit bumpy there. I'm just going to separate this bit of sticky skin. I think we just got a bit of clarinetting, so I just left a little bit away. It's not going to cause the patient any problems. See, it's not as red, the ear canal, in comparison to their right side. It wasn't as impacted, so I'm just going to mop up some of this oil, wet wax skin. And then this is a zoomed out image, and we're going to slowly zoom in frame by frame. Well, I think the next one is really close up. You can see some of my instruments in the background that I used. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.